ensure that do not increase your alkalosis so that it affects your various electrolytes on the other hand. You can consider low doses of bicarb or THAM, often the in infusion form. You can consider that for around 48 hours. Maintain your pH. You would be requiring frequent blood gases. And concentrations of the sodium bicarb should not increase your 0.5 milliequivalent per ml and should not be infused at the rate of 1 milliequivalent per ml per minute. Okay. Adverse effect, it reduces the oxygen delivery to the tissue that is affected because you shift your oxygen curve on the left side. And so data was based on very small population. So usually systemic alkalosis is not equal to respiratory alkalosis in treatment outcomes. Usually, the neonates who were treated with alkali infusion did not show a decrease in mortality and had an increased risk of ECMO and prolonged oxygen dependency. And neonates treated with hyperventilation showed a decrease in the use of ECMO without increased pulmonary morbidity as measured by use of oxygen under 28 days. So if you can create respiratory alkalosis, that is good, but metabolic alkalosis is not equal to respiratory alkalosis and may not be equally beneficial. Okay. Next, primarily the vasodilator which is used is nitric oxide. Potential benefits: causes pulmonary, it is selective, it decreases inflammation, it has more benefits, decreases the vascular leak, so lung edema will decrease, it preserves your surfactant function, it decreases your oxidant injury, it preserves your VEGF, and it helps in pro-inflammatory gene expression. So next. So non-ventilated versus ventilated alveolus selectively reduces PVR without reducing your SVR. So that is an important thing, and redirects blood from poorly aerated areas of the lung to the better aerated. So that is again a microselective effect which you can get. So it kind of increases your intrapulmonary oxygen delivery, which we know happens through the pores of Keeves and Scene. So that oxygen is better distributed across the lung, and we know that more the alveoli are involved with oxygen, so better the PVR starts decreasing even more. Okay, so you can see Cochrane review. Comparison of inhaled nitric oxide versus control on outcome of death. So that is beneficial, or need for ECMO. So that is beneficial. The next outcome would be INO versus control on outcome for just death is equivalent, and need for ECMO that is better. So combined outcome of death or ECMO is better, and ECMO use is lesser with INO. Okay, next. So the guidelines: patient profile should be more than 34 weeks, should have an OI greater than 25, should have an echo evidence of PPHN with extrapulmonary shunting, and congenital heart disease must be ruled out. The starting dose is usually 20 parts per million. Monitoring for methemoglobinemia should happen within 4 hours of starting, and thereafter at 24 hours interval. The duration of treatment usually is around less than 5 days. The discontinuation once your FiO2 is less than 0.6, with increase of FiO2 less than 0.15 after discontinuation, and even after discontinuing it does not increase by more than 0.15 from your stopping value. ECMO availability: if used in non-ECMO center, arrangements should be kept in place to continue INO during the transport. Next slide. Ventilator settings are kept same for the 30 minutes. Response delivered on the basis of increased PO2 after 30 minutes of delivery. Full response, one would say, when your PO2 increases by more than 20, partial response between 10 to 20, no response less than 10. So these are the things which you need to monitor. Your saturation, your PO2 should increase, Your saturations must increase. If that is happening, then it is working properly. And once your full response is obtained, then INO is maintained at 20 ppm till weaning criteria are met. And in cases of partial or no response, then you can consider your discontinuing your INO. Doses higher than 20 ppm have been associated with more adverse effects like methemoglobinemia, so usually not recommended. And almost around 40% of infants with PPHN do not respond or sustain a response to INO. So that is also important. So it's very important that you maintain the homeostasis, because it's not only the INO which is going to make the difference, but entire normothermia, the entire metabolic disorder, metabolic components have to be kept into account. Sedation is there; those things have to be also taken into account. Weaning. When to wean? Once the baby is clinically stable on FiO2 of zero point 0.6 or less, usually INO is reduced by 5 ppm every 4 hours until your 5 ppm is reached. Then further reduction by 1 ppm every 4 hours till 1 ppm is reached. And if thereafter no deterioration is there, then you can stop your INO. And if you feel if there is increase in the FiO2 requirement by more than 10%, then you have to return to your previous INO dose. A little bit about the other agents on, like adenosine basically stimulates your theophylline sensitive A2 receptors on the vascular endothelial cells, resulting in release of intrinsic nitric oxide. RCT, there were beneficial effects compared to so PO2s were better as compared to the baseline after administering adenosine, and resulted in higher PO2. Okay. Next, magnesium sulfate produces vasodilatation by antagonizing the entry of calcium into smooth muscle cells, and other actions like suppression of the release of catecholamines, activation of adenyl cyclase, reduction of sensitivity of smooth muscle to vasopressors, helps in sedation and muscle relaxation, reduces oxygen tissue demand. Studies, you can say that the oxygen index and the mean airway pressure was significantly reduced after 72 hours of therapy. The loading dose of 200 mg per kg over 20 minutes, followed by infusion of 20 to 150 mg per kg per hour, can be tried. But the Cochrane reviews currently recommend on further RCTs before evidence can be. So current lack of evidence exists. Okay. Next, calcium channel blockers. They produce vasodilatation, and the evidence is not very strong on that. Okay. The next would be, they may have a therapeutic benefit, but usually not routinely used. Prostacyclins, PGE1, mainly used if the duct is not. Prostacyclins are mainly mediators of pulmonary vasodilatation, and not sufficient studies are there, so one cannot routinely recommend these agents. Next slide. There are studies currently ongoing on these, so until and unless we have much evidence on these, we cannot routinely recommend. Okay, bosentan. Next. So bosentan is your specific competitive antagonist of both types of endothelin receptors, slightly higher affinity for ETA as compared to ETB. Usually it is used in pediatric patients. At this point, neonatal evidence is lacking, so that is not routinely used. Can be tried under extremely resistant cases of PPHN. Next would be your sildenafil, that is your PDE5 inhibitor. That is usually the usual vasodilator, which is under in centers which usually don't have INO. So we saw the action of sildenafil by inhibiting your PDE5. It was increasing your CGMP, and CAMP was also increased. So that was resulting in pulmonary vasodilatation. Next slide. Hyperoxia diminishes your pulmonary vascular responses to endogenous and exogenous nitric oxide. A dose-dependent effect of hyperoxia was observed, as indicated by stepwise increase in the PD5 activity, as the oxygen concentration was increased from 21 to 50% and 95% of oxygen. So it is beneficial, and it also improves your RV dysfunction also. So it will help in your RV afterload reduction by decreasing your PVR, and also improves your RV systolic functions also. So Cochrane review on 3 studies, 77 infants. Uh, there were limitations in these studies, but there was a significant reduction in mortality, and NNTB was 3. So sildenafil is definitely an agent to be considered. And you can see that the quality of evidence is moderate. So that continues. Even oral sildenafil, next slide, has been used. And that also you can see in various doses, 1 to 3 milligram per kg every 6 hours. Hypotension might be caused, but there was beneficial effect. It reduces your oxygen requirement. OIs were improved. The risk may be slow administering with bioavailability issues may be there. So you cannot rely on this at the acute time. Next. Milrinone, that is your another important agent. That is primarily because it has inotropic and vasodilator effects. So PPHN, the pH is reduced, your LV dysfunction is improved, your RV systolic dysfunction is improved, your hypotension can be caused, but that you can closely monitor. So the usual dosage would be 50 mics per kg, loading followed by a maintenance of 0.3 to 1 mics per kg per hour. That is the usual dose which is used. Okay. So next, milrinone may be the pulmonary vasodilator of choice in the presence of PPHN with LV ventricular. So that's the usual cases. If you have LV dysfunction, milrinone plus minus epinephrine with INO. And if you have a normal LV function, then INO would be a better choice. There is no RCT on this efficacy, but we have mainly case reports and case studies. Outcomes, mortality. So outcomes of and neurodevelopmental sequelae. So PPHN has got a high mortality rate of approximately 10%. It leads to later on reactive airway diseases in almost a fourth of the survivors. Many of them will have feeding difficulties and poor weight gain. The survivors continue to have neurodevelopmental impairment, so that monitoring is also important. Prevalence of late sensory neural hearing loss to the tune of 6%, and intellectual disabilities are also there. Okay, so now I'll conclude with the take home message. So PPHN is characterized by elevated PVR and myocardial dysfunction. Consider impact of oxygen and ventilator, target SpO2 90 to 95%, avoid hyperoxia, avoid hyperventilation or soda bicarb therapy. INO is an effective pulmonary vasodilator, but issues regarding its side effect and availability exist. Evidence for adjunctive therapy like sildenafil and milrinone is promising. Consider cardiotropic support to optimize cardiac output, systemic hypertension to be avoided. Thank you.
Thank you, Dr. Bikramjit. Bijan, please sum up. Dr. Bijan.
Thank you, Dr. Bikram, for your insightful presentation. What we have learned from Bikramjit's presentation is that in most of the infants, more than 90% of the... Sir, am I audible? Hello? Hello?
Yes.
Yes, sir, you are audible.
Yes.
So what we have learned from Bikramjit's presentation is that more than 90% of the infants, the normal transition occurs. That means when a baby is in utero, like alveoli is full of fluid, there is increased pulmonary vascular resistance, and there is decreased systemic vascular resistance. But as soon as in the first few hours, the pulmonary vascular resistance falls and systemic vascular resistance increases, duct closes, and foramen oval also closed. This happens most of the patient, like in other 90% of the infants. But in some patient, as he has rightly described, because of some primary reason or secondary reason, this normal transition may not happen. If the normal transition does not happen, then the PPHN can set in. Second important thing he has highlighted in PPHN is actually extrapulmonary shunt, right to left shunt. It is not intrapulmonary shunt. Because of from pulmonary etiology or from vascular etiology, there may be some extrapulmonary shunt. That means if you want to diagnose PPHN, there must be shunt either the atrial level, that is foramen oval level, or the ductal level. That's why we need an echo to establish the diagnosis of PPHN. Second important thing he has highlighted, many a times some duct-dependent heart lesion may appear or may behave just like PPHN. So an echocardiography is a gold standard to diagnose PPHN. He has also highlighted some of the tests that we can do, but this is not practiced in routinely in patients like hyperoxia test. But clinically, we can have an idea if the baby is highly labile, the saturation is disproportionate, the lung expansion is good, baby is not having mass retraction, but still there is some problem. One of the pointer I should do think in our clinical practice, many times you find that you optimize the ventilation, there is no retraction, but baby is desaturating. So in that case, you may suspect PPHN. Second important thing he has highlighted, when you treat a baby or manage a baby with PPHN, all the events which can actually increase the pulmonary vascular resistance, that should be prevented, like light, noise, pain, etc. And the physiological milieu should be maintained. Third important thing is that actually whatever you give, either you give INO or pulmonary vasodilator, there should be optimal lung inflation. That means lung should neither be overinflated or underinflated. If there is overinflation, then also there will increase pulmonary vascular resistance. If there is underinflation, then also there will be increased pulmonary vascular resistance. So a PPHN, one saying is there that if there is a PPHN, resident cannot actually go away from the patient. That is the importance of hypoxic respiratory failure. So I think Bikramjit has highlighted all of the things, especially hemodynamics and etc. and ventilation strategy. So we can take few questions. Let us see what our questions are in the chat box. So there is a question: how many fluid boluses can be given before adding inotropes for management of PPHN? Vikram.
Okay, so here also echo would be helpful. So you can see your IVC size and then you can decide upon this factor also. But usually maximum one would go for two boluses of 10 ml per kg each. They should be slow, and then you need to see the response to each of these boluses, both clinically on your PO2s, on your saturations, and everything.
So what he's saying that you just do an echo, see the volume status of the baby. If the baby is already hydrated, you may not give fluid boluses. But maximum 2 boluses can be given and you see the response. If there is no response, that means it is not fluid responsive shock. And I think if we can remember what you were speaking, in PPSN first there is right ventricular dysfunction followed by biventricular dysfunction. So this actually shock is basically cardiogenic shock because of ventricular dysfunction, initially right ventricular, left ventricle. So there is not much role to fluid unless there is some dehydration or fluid loss, etc. Second question is, why is hyperoxia test discouraged now?
I think this is the era has changed. You have the echo, so you will not waste your time, and if the echo helps you immediately diagnose, because your hyperoxia test has its own fallacies. It is difficult to do because for every peak or PO2 you will be stimulating the baby, so that's usually discouraged. Nowadays you have echo, so that helps you a lot of information, right from diagnosis to the severity of PPHN to your volume status to everything.
So what he is saying that actually echocardiogram is the gold standard of diagnosing PPH and also management point of view and response to therapy. Second important thing is if I can remember in one of the slide, you was telling if there is hyperoxia, there may be release of free oxygen radical,
Yeah.
and that may be counterproductive in a patient of PPHN. So there will be more uh, release may be there, and that may increase the further increase in the pulmonary pressure. So that is another reason. Third question is that should we keep FiO2 high if suspecting PPHN? Is oxygen good or bad for PPHN?
So oxygen would be your strongest vasodilator. So you need to keep your oxygen high, but maintain your PO2s ideally. Because if you keep your oxygen too high, that may be even detrimental because it will keep on generating your oxygen free radicals, which might lead to further worsening of your PPH.
Second important thing is that one important point to remember in case of PPHN, suppose you are ventilating a baby is doing well, suddenly you cannot do sudden de-escalation. Sudden de-escalation may lead to catastrophe to the baby. So whatever you do, it should be gentle, it should be slow reduction. Many times we ventilate a baby, there is good saturation, we think we reduce the FiO2. You can reduce the FiO2, it should be very slow. So as he has rightly said, if in case of pre-ductal, it is mid 90, and in case of post-ductal, 85 to 90, if I can remember from his presentation. That is the target.
Yes.
And I think Vikram, we have told like that. But, post-ductal 85 to 90 and pre-ductal
Yes.
it should be
Yes.
mid 90.
Yes.
And you should not do reduction very fast. You may
No,
end up
not.
with that. Any more question? If you I think Bishwajit is asking, is dopamine contraindicated in PPHN to maintain BP?
It is not contraindicated, but if you want a cardiotropic drug, then epinephrine works better than dopamine, and dopamine has got more pulmonary vasoconstrictive effect than epinephrine. But do remember that whichever you are using, it has to be at a very low dose because otherwise you may end up worsening your pulmonary hypertension.
He's right. At lower doses, there may not be pulmonary vasoconstriction, but dopamine at higher doses may cause pulmonary vasoconstriction, like more than 10 micrograms. Some people say more than 12 micrograms, like that. So you should be very careful when you are using inotropes like vasopressor like dopamine. At higher doses, it will increase the pulmonary vascular resistance. That is why he has what he was highlighting. You should do a echo and continuously monitor the hemodynamics and see what you should do and how you should titrate all these inotropes. Next, Mohammad Asif is asking effect of nitric oxide on systemic pressure.
Usually, it is selective for pulmonary vasculature. So, usually, your systemic pressures don't fall because of INO, but it usually falls because of your LV dysfunction. So, if you need to monitor your LV functional status also, and if you find that that is not good, then you can consider Mylenol.
I think it is there. Nitric oxide is a selective pulmonary vasodilator. That is the importance of nitric oxide over sildenafil. Sildenafil may cause pulmonary as well as systemic blood pressure to fall. That is the problem. When
Yeah.
you have got the facility of nitric oxide, then you have to either use milrinone or sildenafil. But these two drugs has got effect on systemic blood pressure also. If there is fall in the systemic blood pressure, there will be more right to left side. Another important point, I think, if you use nitric oxide, it is better to use nitric oxide with high frequency oscillation ventilation because we have to recruit more and more envelope for better distribution of nitric oxide if you have got the facility. I think
Yes,
Vikram, it
yes,
is
sir,
better to use.
definitely.
So, any more question is there? Then, if you know, we can actually directly ask the question also. We have got few minutes with us. I think there is not much question. Thank you, Vikram, once again for that
Thank
excellent
you.
presentation.
Thank
And
you.
I think our viewers have been benefited with your presentation. We will be looking forward to meet you all on 12 and 13 at our physical workshop. Thank you very much. Happy Teachers Day to all of you.
Thank
Thank
you.
you once
Same to you.
again and good night.
Thank you.
Good
I
Good
think there
night.
is no more.
Good night.
We can close the session tonight.
Thank
Thank
you.
you. Good night.
Thank you, sir. Good night.
Good night.
Good night.